Hi, good afternoon, everyone. Thank you so much for joining this session this Friday afternoon. This is a solution-based session today. I had quite a number of people over the last few weeks saying they've been enjoying the other previous sessions that we've been doing, but they've been more sort of focused on discussions around the problems that we've got in various areas. And there was a definite feel of, can we have some more solution-based sessions? So today is the first one of these managed around a solution focus, and today's topic is frailty. Got some brilliant people on the panel this week. I'm really, really pleased with the panel that we've got. In a minute, we'll go around and do our introductions, and then what will happen is that DJ will give us some time focused again on a solution. So I'd really love it if people in the audience could be proactive and supportive and feedback on what they feel around what we're talking about, and also share their insights. And you can do that either through the comments in LinkedIn, and also if you could also do it in Insight Genie, that'll be brilliant, because then we can collect your insights and your experience and your know-how, which hopefully can be a positive source for DJ and his team to progress further, take your ideas, take your insights, and improve the solution even more. That's what these sessions are about. It's about proactive reform for the public services, and for today, for the NHS in particular. So just before we do our round robin introductions, I'm just going to quickly share how to utilize the Insight Genie link. So in the LinkedIn comments area, I did a post about an hour ago with the link to Insight Genie, where you can go in and add your insights for us. I'll just quickly share screen to show you what you will get and what it looks like. And it will be this one. Share. So hopefully you can see that. What will happen when you first click this link that ends in 6,300 that you'll find in LinkedIn comments is you'll pop into this area. You'll get a pop-up box which is basically saying, please don't enter any personal data, because we don't want personal data in the story. We want you to tell your stories if that's relevant, but don't add any personal details in there. And then it's essentially as simple as this. What do you think to the solution that we're discussing? And are there any strengths and weaknesses to the solution? What are the improvements that you could think of? So you might go, this is great, but actually if you could do this and this, it'd be even better. And then at the end, is there anything else you think we should look into, research, etc.? Anything you've not told us in here that could help us progress with this solution for our NHS reforms? So really straightforward and really simple. What we're trying to do with this is to move us from a belief that qualitative evaluation takes months. We can do it in minutes, and it can be really valuable and really inexpensive.
Anthony, can you hear me?
Yes.
Maybe for the sake of the people listening, you could explain that the results of that are going to come out by the end of the session.
Yeah, no, really good point. So you can all, as we're talking now and contributing, you can enter your thoughts and insights into Insight Genie between now and 12:43. At 12:45, Insight Genie will run, and then I'll pull the report up about 12:47 or something like that. And then as a panel, we can go through it and discuss what's been discussed in the audience.
You've also got one comment saying that they can't see any comments in the LinkedIn thing. So maybe while we're introducing ourselves, you could answer Matt's concern about not being able to see the link.
Yeah, okay. I'll do my first introduction then, and then whilst you're introducing, I'll whiz into LinkedIn and just post it again. But it's in the comments section of the event. But I'll go and repost that link. Okay, thanks everyone. Again, thanks for coming. Really privileged to have this amazing panel. My name's Anthony Lawton. I'm the founder of Fit to Care and Insight Genie. I'm a dedicated public sector advisor. It's really my area of focus. I work a lot on cognitive science and AI so that we can bridge that gap between senior managers and decision makers and the front line, so that we can make much faster and much smarter decisions. That's really my drive. When we can get engagement and staff feeling like they're valued and energized, they can make such a massive difference. The ripples that sends throughout the community and the millions of people that they touch is amazing, and they make a real impact. So my sort of mission is to connect people and connect information so that we can really drive and improve outcomes in the public sector. So I'll just, on my screen, Jonathan's next. Sorry, DJ made a good point. In terms of frailty, I haven't been massively close in my 17 years in the NHS to frailty. My closest experience has been I lost my mother last year. So I went through a lot of pain in the system over 18 months with my mum. So I feel like I'm quite close to it personally. So I'll hand over to Jonathan next.
Thanks, Anthony, and thanks for sharing your lived experience of it. So I'm a consultant surgeon by background. I worked in the NHS for 22 years. But I left the NHS a few years ago and now work as my own healthcare consultancy across working with the NHS, academia, commercial organisations, really around data, digital AI and healthcare, and specifically trying to help translate between that gap between clinical teams and should we call it, managerial problems and commercial companies, academia and the system. So pathway mapping, product design, value proposition. So as part of that, I've been working with the Helix Centre in Dewar College, London, working on an intervention around frailty care. And a lot of that's focused actually at the earliest stages of frailty rather than perhaps our stereotypical view of frailty. So I've got that work to draw upon. And then in my previous clinical career, I managed an awful lot of patients with hip fractures, and I operated on, the oldest person I ever operated on was a 104-year-old. So the actual clinical intricacies and difficulties of managing this population and working with this population to try and get the best outcomes for them is something I'm familiar with. So over to the next man.
Brilliant. Yeah, I think Shane's next on my screen.
Great, thank you, Anthony. I'm Shane, I'm the medical director for Careful and help head up the UK arm of things. Really my work as well, when I was working as a clinician in the NHS, I did a lot of care of the elderly work, and seeing fit and healthy people have frailty return because they couldn't actually get to their destination they needed to go, whether that would be back at home or into a care home. So having been treated in hospital and then deteriorate again with a chest infection or urine infection just because of inefficiencies basically in the discharge process and the coordination of all the teams that look after frail people, that was something that was evident every single day really within my NHS work. So looking forward to the conversation today.
Yeah, fantastic, thanks a lot. And then over to Rui.
Hi, thanks, Anthony. So I'm a biochemist, but also a continuity of care specialist. And currently live in the Middle East, but have lived and worked in the UK, in North America, and China. And I think it's a very common problem across the globe that we have trouble managing vulnerable populations and frail populations in particular. And so while we, as you said, typically think of frailty as the elderly, in a preventative approach that I've taken before, we often overlook frail populations, that are young, or frail populations or vulnerable populations that have other problems and other conditions that also then, over time, lead them to have to go in and out of different organizations, different systems, different healthcare systems. So from a private perspective, and this is how the Middle East operates predominantly, there is an equivalent issue, but in the dealing with private entities, which I know that in the UK we are building towards as well, public-private partnerships, as we face, sort of overwhelming populations going through the NHS. We need a way that this care becomes more joined up in order for clinicians to do their job better and for patient outcomes to be better as well. So a statistic that I'd like to talk about later on perhaps is how frailty populations are just huge across the globe, and some are alarming in other parts of the world.
Yeah, really concerning, I guess. And the scope in terms of the scale and the numbers and the costs will be ginormous. I'm sure DJ is going to talk about that. But I think the other point is, yeah, we just don't even think about younger people being frail, do we? It just doesn't enter our minds unless you're in that space, I suppose. And then over to DJ.
Thanks very much. So my name's DJ. I'm an emergency doctor in the NHS and also the CEO of Careful. I've had experience of frailty both in my clinical work, as you can imagine, in the front door of any hospital, you see an enormous number of frail patients coming through, but also my family. We've had a number of my relatives who have been through the sort of frailty period of their lives. And I guess what I suppose we should really recognize is that for many of us, that is our destination as well. So it's of personal interest to all of us that we should try and help improve this aspect of care. So if, with your permission, Anthony, I'll just go straight in and just share a few slides. So the intention is I'll spend just a few minutes talking about frailty in general, about the attempt that we're making at Careful to try and improve the way that is delivered. And then I'll offer the floor back to whoever else on the panel wants to chat about it. And if there are any questions, obviously, in the chat from LinkedIn, we'll try and answer those. So we're just a few minutes of me trying to share some thoughts. First off, let me just see if I can share the right screen. With luck, it says the challenge of frailty coordination.
There we go.
Coordination and frailty. Great. So the Careful is the product that we're going to be talking a little bit about today. But before we do that, let me just mention that this frailty is not just on its own a coordination problem, which of course it is, but actually clinical coordination is a challenge for all aspects of care. You don't have to come very close to any healthcare system to realize that if you cross a boundary, particularly between the acute and the community sectors, you have a significant degradation in the ability to get the information across. People find it very hard to communicate and collaborate across boundaries, and that's getting worse because of the increasing burden of chronic disease, and of course frailty is one of those chronic conditions which we need to address. So just how big is that problem? Ruhi, I'm sure you're going to add to this, but this is something that I've got from the British Geriatric Society. 1 million older people over age 75 are admitted to acute hospitals in England every year, and of that, a fifth will be severely frail. It's an extraordinarily large number, and as I said before, it provides an enormous burden for us, and as Shane mentioned, so when I say us, I mean emergency doctors in particular and emergency departments, but also it creates work and it creates stickiness within the system, because frail patients are hard to deal with in the acute sector, and they're often best not dealt with in that sector. So one of the things that really helps to understand how frailty can be dealt with is by understanding this concept of the comprehensive geriatric assessment, which can take, it can take up to several hours, often half a day to a day, for a comprehensive geriatric assessment to be performed by a frailty team, because they need to really understand all of the components of that person's makeup, social, physical, mental, in order to be able to come up with an adequate care plan. Of course, this is something which we don't have time for in most of the services that we provide. So emergency medicine, primary care, really not geared up to giving people, several hours of consultation time. And so frailty services, they need to be given the space to make these assessments, but also to then coordinate the care that comes out of that and the plan that comes out of that. So when that plan comes together, it involves enormous numbers of different people, different teams, different locations, and coming back to the very first slide I showed of that the difficulty of coordinating care across time and space. This is, if you like, the sort of the problem of coordination writ large, because you've got pharmacies, ambulatory centres, hospitals, hospices, very often care homes, the home environment itself, and all of these places. I mean, it mentions in this, again, this is from the British Geriatric Society, mentions places of worship and day centres and all sorts of other things that contribute to a frail person's quality of life. So we would say that this problem, then the problem starts at this point. So you've got an idea of what you want to do with the patient and how to bring them to all of these services together. But instead, what happens is we spend all of our time recording what we've done and very little recording what's going to happen in the future. And in the interim, about what's going to happen right now, we spend a lot of time talking to each other on the phone, sending emails, WhatsApp messages, printing stuff out, handing things from side to side. We don't have, as a matter of course, coordination systems which are designed to help make that process easier. And so that's why we built Careful, which we want to just talk a little bit about. I don't want to stress this too much, but I think talking of solutions, as Anthony said, what you need is something which is simple to use, easy to onboard, is clinically focused, and concentrates to the large part on actions and next steps and who's doing what next and how do you hand over the actions from one place to another, and that can be used anywhere at any time. We include a secure chat to replace the dependence on WhatsApp and similar platforms. And it needs to be affordable, it needs to be interoperable, and it needs to be compliant and safe from a data security point of view. So this is roughly what it looks like. We can create in this a series of actions which allow people to then see what's happening, and we can create a series of statuses which shows where the patient is in their journey. And different teams can see the same picture across those various multi-professional sites. The data we've got from using this in the acute sector is that the amount of time it takes to get information from one team to another, even within a hospital, drops from an average of 60 minutes down to an average of 0, essentially. So we can take between 60 and 30 minutes away from the time it takes to make a referral inside a hospital, and I'm sure that would be substantially higher as we work around the community as well. I'll mention that we have this 30 minutes, which we've mentioned here. The number of people waiting inside the ED where we were using this has also fallen a lot because people are able to get people through the ED quicker, and so this applies, of course, to other settings, and we have applied Careful in a number of different settings in a number of different parts of the world, and we have some very happy users. One of which I'll just stress because it's very relevant to frailty, is Dr. Henry Konopnicki, who is a GP and geriatrician who works across care homes in Melbourne, and he has now got Careful in hand, in his pocket, every day in order to find out what's happening with all of his 100 elderly care residents. And he never had that before Careful. But more importantly, he can also communicate with the pharmacy and his nurse specialists and everybody else on the same platform. And it really reduces the amount of complexity in creating the community that you need to look after a frail elderly person. I'll show this because it's here, and if anybody wants these slides, they're welcome to request them. But this is the case study of that particular aged care facility example that I just mentioned with Dr. Henry. So I think that's what I'll finish on, and just say that we have a solution, as Anthony said, to this particular conundrum about how to bring people together. And we'd be interested to hear your views as in the audience, but also to hear also from Jonathan and Anthony and Ruhi and Shane. I'd be interested to get your view on this particular problem.
Brilliant. Thanks ever so much, DJ. Really interesting, isn't it? So can I kick off with the first question or two? I've written down loads actually, but I guess we're focusing on frailty here because it's such a massive issue for the NHS and the scale and the costs associated with it. Because if we don't get things right first time, which is a big drive for me, the costs downstream just multiply, don't they? Become massive. So frailty is a massively important area for us to focus on, to put the spotlight on. But actually, it feels like the answer is a generic one of communication across different teams, whether it's in the same hospital or social care or GP world. It's the same issue, I guess, for every patient. Is it that simple?
Well, I think I've spoken enough, so I should hand that question on to whomever wants to answer it.
I mean, yeah, I'll jump in. I think that it almost is. It is that simple in some ways, because just to take the example that DJ gave about, the reduction in intra-hospital referrals, even though we have across the NHS differing levels of digitization and everyone seems to be slowly getting on board, there are still different silos of information. So, when I was looking after my grandfather when he was 96, and when he would go into hospital, they would have no idea that he'd had a derm appointment, outpatient appointment, a few days prior. His urology appointment wasn't in the notes either. And those things may have been digitized and maybe on bits of paper, but in terms of actually coordinating his care, the time between something happening and then being relayed to a different team who needed to know that information was ending up being multiples of days or even weeks. But we've had the technology for decades to be able to communicate much, much faster than that. So it really is the problem of coordination, because we have the capability to improve things now, but it still isn't being done because people are still using things like WhatsApp. They're still using whiteboards and bits of paper. And really to have a standardized process across the NHS or even parts of NHS would really reduce the burden on staff, basically. And then obviously that has the added on much improved patient outcomes, which is what we're all caring about. So really it's about coordination, but the thing that makes the difference is the resultant speed and efficiency of care. Because as we know, the longer patients are left without some sort of resolution to their, issues and conditions, then the worse their outcomes are.
Yeah, which I think ties in with the point that John Paul's just made around frailty patients can decline a lot faster. So I guess it's more urgent that the comms is swift and prompt and really efficient. I remember back to my right care days, a case, some evidence around for every day that a frail and elderly patient's in a bed, the muscle wastage is just incredible. It becomes really scary, doesn't it? So I guess all this ties in.
Yeah, I mean, just on that point you've made actually about, people lying in bed. So we all know that that's an issue with getting frail patients out of beds. But they did a study on 40-year-olds who are fit and healthy. And the study was simply that they had to lie in a hospital bed for 5 days in a row. And the amount of muscle mass that they lost while being fit and healthy, I think was like something between 30 and 40%, which is extremely significant for just 5 days of being in a bed. So it really has, long-lasting implications in terms of recovery and, how much scope for return to fitness there is.
Yeah, incredible. I'm going to have 100 questions, so I don't know if Jonathan wants to go next.
Yeah, thanks, Anthony. I think the other thing about coordination, and there's the intra-hospital, as you say, and then there's between organisations, and thinking about, we've got societal costs to this that are hidden, haven't we? Like people who are helping and supporting their older relatives through a system that isn't, they suddenly become unable to manage their care because they're not sure what's going on. You know what I mean? And as you say, if the hospital doesn't know that you were in urology clinic yesterday, and so that piece of advocacy, and we know that that won't fall evenly, social determinants of health inequality and all those things playing in, you sort of need this single source of truth, because that's one way to start to try and make sure everyone gets the same, rather than someone has a pushy relative with them versus someone who doesn't, or someone who, I've got the diary of all the appointments we've ever had, coordinating their care, and the other person who's at the whim of the NHS infrastructure for the team. So I think there's something about trying to even up for people. But also in the examples given, I think, DJ, the example of a care home being able to be far more linked to its primary care resources, its physio, its pharmacies is very powerful. You see the amount of interactions at that level. But even when we go younger, I think, taking this to the pre-frail group, so they're people who won't know they're frail. But if you look at people who sustain a wrist fracture over the age of 60 in the NHS, approximately 30% of those are pre-frail. So they're already onto a trajectory, but no one will be noticing that. And actually can screen for that reasonably quickly. But then, do you know what I mean? Who's tying that in? So we currently look for osteoporosis if you're lucky. But the point about, well, what are we doing for their muscle mass? There's some very simple rehabilitative programs that could be leaning into that. So again, coordinating care we've got sort of interventional care, but then to Ruhi's point, we have the sort of preventative care. And if we can change their trajectory at that point, then, the resource problems are further on. So I think there's lots to do, but one of those issues, sat in fracture clinic with 120 people, trying to coordinate that on WhatsApp, emails, whatever, is never going to work. So you need a hook, somewhere to put all those things. So that's just some initial thoughts from me.
Yeah, just to add to that, Jonathan, I think, two things are critical in that situation. You need agility, and you need speed, and you need the right information, not all the information. So because, we know that we've got to deal with, hundreds of fires at the same time. If there is no common platform, then you can't start with that sharing of what's important. So I think the paradigm shift is in healthcare to say, well, we respect privacy, we respect the need for patient information to stay sacrosanct, but there's an element of the information that needs to be shared more easily and more seamlessly in a more coordinated and controlled way, rather than this sort of crazy shotgun approach that we're using, where when there's a need, you find the best, easiest bit of paper or phone call that you can use, which just wastes time and prevents us from taking care of more people than we need to earlier.
Okay, that's really interesting. Can I jump in with another question from that thread? So my gut feel, I'm starting to get into practical mode. So I really love the point, DJ, about simplicity. A big part of my drive, and I've been doing some work with Sue Bacon, who's commented in the audience, around the simplicity of systems and how complex it is to get data out of all the different systems, and things fall between the gaps and all that sort of thing. But I guess the challenge we've got, and I guess the challenge you've got, is how do you bring in, because I guess a lot of people on the face of it would say, God, not another system, more duplication, more data to enter, more than once.
Yep.
How do you tackle that? But I guess, Ruhi, you were just hinting at, you're not trying to replicate or replace the existing systems. So I think from my perspective, just learning how you're going about that is really interesting.
Well, if I can jump in, if you don't mind, I think it's a really good point that you make, Ruhi, about this idea that you should share the information. But it's interesting, the Caldecott principles, which are familiar to people working in the NHS, actually says, I think it's the 6th one or possibly the 7th, that says you have a duty to share the information that is necessary. But GDPR says you should only share that information which is relevant. They're actually, at the risk of blowing our own trumpet, Careful does precisely that. And we've thought about this very carefully, because what you don't really want is to give, even though some doctors will say this, I need access to your medical record in order to be able to treat you. Actually, you don't need access to their entire medical record. You need to have access to that part of the medical record which is relevant to the decision that you're making. And actually, if you're given access to the entire medical record, you're stuffed, because you can't sift through it. This is something that happens when you create information exchanges, health information exchanges. What happens is you take a massive silo of data on one of these big hospital systems, and then you take a massive silo of data, let's say from your community care, and you crash them together, and now everybody can see everything. Well, actually, that's not really helpful. This also means it's twice as impossible to find out what you need. And so what Careful does is it asks people to summarize the information that they care about for their team, and then make that available to other teams. So one of the ways to think about this is to say, when you used to go onto a ward, when we still had the ubiquity of whiteboards, you didn't go to the patient's notes to find out what was going on. You went to the whiteboard and you asked the nursing staff, well, I would, as a visiting doctor to the ward, I'd say, tell me what's going on with so-and-so. And you'd look at that and you'd see all of the information about the ward in summary, and the columns of the whiteboard would be what was relevant to the ward. If you went to a different ward, you'd have different columns because they're doing different things. And if you went to the physios, they'd often carry it around in a book, but they'd essentially have the same mechanism of having a list of cohort of patients with set bits of information for which patient. So what we're trying to do is we're trying to be able to get the physio to see the nursing board, and for the ward board to see the one in theatre, and then more widely in frailty and in the community, for the elderly care home to make their critical information visible to the pharmacy, and for the pharmacist's questions to be visible to the GP, without bringing vast amounts of integration and health information exchange or data lake thinking to this. It's really about the sliver of information that you need to make the rapid, high quality decision that you need to make at that point. And actually, the people who know what that information is are not the IT department. They are not the leaders. They are actually the team that are managing that patient. They're the ones that know what the critical information is. So at risk of repeating myself, so Shane, your point about the urology appointment of your 96-year-old grandfather, he doesn't need to see all of the urology operation notes or whatever. He just needs to see that the urology team have said he's got whatever it might be. Let's imagine, I don't know, prostate enlargement or bladder cancer or something. This is the treatment he's had, and this is what we think the prospect is. And that's the 3 little bits of information that everybody else needs to know. And you can bring all those together with Careful in a very easy, agile, and flexible, self-configurable way. And that's why we've designed it the way we have. That was probably a bit of that answer.
No, that's really interesting. Really interesting.
John Paul's made a very good point. He said it's having different windows on the same information, but every decision maker has a different window. And that's exactly where information falls through the cracks and all these issues start to crop up. That's exactly it.
So are you, DJ, are you taking any information from those other systems, what you class as relevant, or is it more around, this is where I feel the NHS needs to prioritise? It's more of the clinician that's doing the handover, putting the relevant information in, or are you drawing from those other systems?
Well, both. I mean, I think the point is that you start off by just simply replacing your WhatsApp and your spreadsheet and your whiteboard with something which is easy, because you're going to write it on the whiteboard or enter it into WhatsApp anyway. So now we're going to just make that easier for you, because you don't only have to do it once. And then you can attach through standard technology into the other bigger system. Sorry, Jonathan, I think you were going to come in there, were you?
Yeah, I was just going to say, I think it's also the churn within the hospital. So, my specialty was cancer care largely, where, you're writing internal referrals, say, dear DJ, I've seen this patient, can you please provide radiotherapy? And I have to sort of refer you for radiotherapy, even though we've sat next to each other in the MDT meeting, talked about this patient. We're in the same hospital, the same, you know what I mean? It's like, how do you drop the friction down? Because then I send you a WhatsApp as well, going, referrals with your secretary, DJ, can you get them in tomorrow? And, I think when we look at it's opportunity cost, isn't it? So, and I think that maybe we could come on to how do you build a business case for these things, but there's the saving of time and effort is significant, isn't it? Just in that endless chasing around, and my secretary's not had that letter yet, and so not just frailty, but like saying things like cancer, or where you have lots of handovers within the hospital, but to treat one condition, often against a timeline. I think a system such as this offers a value there.
So just to talk to a comment that Sue's put in, we need more communication about, activities of daily living. I think that can promote and prevent escalating issues with frailty. Definitely something that should be made more frictionless. No pun intended, right? But if you want to get different teams involved, it's almost impossible, because the barriers come up instantly from one organization to another, or as Jonathan, you said, within an organization, the barriers come up as to, no, well, this is the process that you need to follow. It just doesn't need to be that hard. I mean, in day-to-day world of improvement in productivity, and with AI coming on now, we don't have to ask permission to bring on Slack, to bring in teams from different organizations, from different areas of work, to help us do our jobs or our daily life quicker, faster, and in healthcare's point of view, safer. We really don't need this friction within healthcare.
Can I just add on to that? And I think, at a time when we know we've got workforce pressure, we've got an unhappy workforce, because people like me who no longer are in the workforce, the number of times my holiday was broken by having to feed back. I've had a WhatsApp about a patient that's come to me, I'm on holiday, I'm now chasing around a colleague to get that message to, and that'll be replicated hundreds of times across the system. And there's no record, is there, of that interaction that so-and-so said they'd do it to me in a WhatsApp message. So again, having a system where, I believe, DJ, your system can almost, should we say, who's in the chat at the minute, for want of a better word. So I'm going on holiday, so I can put Shane in and I step out. I think, we have to lean into workforce and being at work 24 hours a day, 7 days a week. That's why we've struggled to retain people, isn't it? You need to, unfortunately, be able to go on and off.
Yeah. I'll just remind everyone that's in LinkedIn, we've got 10 minutes left, or 8 minutes, just to be safe, to make your comments into Insight Genie. I feel like I'm too engrossed in the conversation and things are moving fast that I can't actually dip out and do my contribution, but I'll verbally do mine. I feel like if I put myself into sort of a senior manager's position, thinking I'm interested in this, what I would love to see would be that friction mapped out. So at the moment, let's take a typical pathway with the different regions and the different areas. So primary care, community care, the hospital, and literally map what's physically happening at the moment with a typical patient. I used to do this with right care scenarios, and we'd map out all the flows and the paths and what is actually happening now. And then we'd go, and this is what will happen with Careful. And just so we can physically see the friction reduction. I think that would be so helpful if we could physically show on this screen now, that's a typical pathway with 87 communications in 15 different systems. And this is the proposal now. And we've halved the amount of communications. I'm just making this up. But if I could see that as a manager, I'm going to go, okay, I want to know more about this.
Well, can I just come back at you there, Anthony? But as a manager, this is a bit of, you have a magic manager available who's going to take an interest in this. One of the challenges that we've found, and if anybody in the LinkedIn audience can think of a way around this, we'd be pretty interested to hear. There is no man for this problem. And that is, a man is the person with the money, the authority, and the need. So I'm not intended to be sexist. I think it's an old expression. You need somebody who has a budget, and they see the need for this solution, and they have the authority to make it happen. The problem with the NHS being so massively, I should say, disintegrated, almost dispersed into different trusts, different authorities, as a result of all of the changes that have happened, is that there is nobody, not even in the ICSs, whose job it is to mandate the solution to this problem. Now, this is a question metaphorically to where streeting is. How are you going to make care closer to home? How are you going to make prevention more prevalent in the NHS? Where are the people who are going to have the budget and the authority to solve the problems that we've just described? And I think this is a really interesting problem for us as a business, but also for the NHS as a whole, is how do you mandate stuff that happens in the gaps between the main authoritative, trusts or whatever?
DJ, I think Chris has a comment which is interesting, and I think we should find out more about how he's broken the rules to make it happen.
Did I say where's street? I said where's streeting. Did I say that? Sorry, so there was a question.
Yes, but I think that his comment below, he had to break the rules to make it happen. Maybe we need to follow suit.
Yes, we do. Breaking the rules would be great, but actually getting different people from different organizations to use Careful as an alternative to the systems that they use already is our biggest challenge. Whether that's paid for or not is sort of irrelevant. I think, for instance, with our the use case that we've been working on with Jonathan potentially is for sarcoma patients, where you've got 200 GP practices, 20 oncology centers and 5 surgical centers, all trying to coordinate the care of these patients across the country for rare disease. Now, who's going to tell them they've got to use this? And that's a practical as well as a commercial question. And frankly, we don't have the answer. If we did, we'd tell you.
Yeah. Is a John Paul a similar feel to it in terms of challenges?
Yes, well, actually, I think John Paul has just mentioned this idea of a business case. So the business case is the ubiquitous barrier between you and getting stuff done in the NHS. It's the case elsewhere, and there's no reason why business cases shouldn't exist. But the question is, to whom do you present the business case for inter-organizational coordination?
Yeah,
it's a challenge. I mean, Shane, you've had quite a bit of experience with this, haven't you? Trying to get different parts of the system to work together.
Yeah, I think Sue mentioned ICBs, and so they are technically at the right level for inter-hospital communications, etc. But coming back to your man comment, whether they have the authority, money, and the need for it all at the same time is not always the case.
Yeah, and so to throw, you know, a completely different cat into the pigeons is, do you start with the patient and say to the patients, you push the agenda because you're at risk of not having coordinated care. Therefore, this comes from the patients and their advocates and their family members, as in demanding coordinated care from everybody who's providing care for them. That's a different way to look at it. But
in frailty, of course, the patients' families are very, very important. For most patients, the patients themselves, of course, are, almost by definition, are less able to advocate for themselves. So that's also challenging.
Yeah. I mean, I think they can, depending on also, you know, if they are elderly or just you know, sort of other frail and vulnerable populations, for sure. They might be compromised, but just taking the case of my mother in a private healthcare situation, where within one organization, the clinicians failed to be able to coordinate between themselves, having access to a shared record. And she ended up with a drug interaction that they also failed to catch. And it just led down a slippery slope. So, you know, we're just having to face this problem in public and private healthcare. It's a terrible problem.
On a more positive note, if I may say, Ruhi, and it's terrible that sort of coordination problem happens even within an organization that has a shared care record. For frailty services, there is potentially a way out of this, in that there are services being set up whose job it is to deliver frailty. And actually, we're talking to one of those up in the Manchester area who may well actually be the people to mandate it within the frailty environment. And I think that's what we're thinking, is that frailty services are actually mandated to join up all these bits. That's what they're there for, and they're struggling to do it technically. So we may actually have a willing customer, I guess.
Chris has just sorry, DJ. Chris has just sort of endorsed the fact of family members having to come together and do that coordinating. So it would be incredible if we had something that mirrored careful for the families.
Of course.
Yeah. It does feel to me like ICBs are the location to get to grips with this, doesn't it? Because they are meant to be coordinating all these different sectors. And I get that, and sorry to bring it back to business cases, but again, if we can physically show that friction and the reduction of that friction, and then tie the numbers to that, there's got to be some common sense applied, hasn't there? I would say, and we've got to make that case to the ICBs, and not just for your services, but for this is going to apply to all the reforms that we've got coming through, isn't it?
Indeed.
Yeah, interesting, very interesting stuff. So anybody that's still tapping away into Insight Genie, if you can do your last full stop anytime soon, because the report's going to run in 2 minutes. But
just to make a quick comment about what Chris is saying, about his mother being in the pathway, and obviously patients and families moving together. I think this is still shows why it's so important that there is something formal within the NHS that is doing the clinical side, because I think that it was mentioned earlier in the call that if you don't have a family around you, then you're worse off, because you don't have that support network to guide you through a complicated system. If you're frail yourself, you might not have the cognitive ability or the strength when you wake up in the morning to be able to work out what's going on. So really the two need to work in tandem for the best outcome for patients.
Yeah, absolutely. And this is joy to me, because Chris is starting to collaborate with us on this in the spirit that I wanted these sessions to be, which is like, let's join together and support each other with ideas and taking this stuff forward so that we can get reform moving. I know Chris is an absolute guru in terms of lean and organizational transformation, so he's a great person to get involved. And given that his mother's going through this, I suggest you guys hook up, definitely. I'll leave you to it while I just go and check the back end and you're never meant to do things live, are you? So I'm hoping this report's run. If not, I'll just go blank for the next 15 minutes.
Shane, if I could sort of come to your point, it was my cogs were whirring during this, and yes, possibly a value proposition around is exactly around, should we call it, patient safety, and I hate that phrase, leveling up. Let's be careful, but for people who are, people on their own. Do you know what I mean? Because there is no, and particularly when we then layer onto that all those other things, so the fact you're ill in that moment, but if you have been affected by, adverse social determinants of health inequality and those other bits, the system cannot, there is no advocate, but if the advocate is at least here going, that's all the stuff, we at least, can be bringing that group of people up to the level of everyone else. Even if that level's not great, we've still shifted some people up. And
yeah, Jonathan, just to say, I completely agree with you, because if you don't know that they're there, you can't do anything about them. So what we're trying to do is say, at least pick them out, put them in an area where lots of people who are interested in helping them know that they're in that area. Right, we're resource constrained, so we might not be able to tackle all of them, but at least we know that we put them into one place, recognize that they have a common issue. And I think that's another thing about the way that Careful has been built, is that you're able to manage cohorts of patients to be seen and then understood by different groups in different places. And that flexibility just doesn't exist in any healthcare system, and it should. We should have that flexibility.
And I think if you think of a clinical pain point, I'm sure for emergency care teams, but myself as a surgeon, where you have an older adult who's maybe got lots going on, who can give you answers, but there's a level of detail you're missing. And what a ray of light it is when a family member or someone turns up and goes, "Oh, there's it," and suddenly you can unlock it and go, "Great, we don't need to do those tests. You can go here," or you can. And the sooner the closer that is to the front door. Because as you say, the minute you're admitted to the wrong destination in a hospital, it unravels, because we do tests that weren't appropriate, that give us results we weren't expecting. So we do some more tests, more results. And meanwhile, to your point, Shane, the sarcopenia and these other physiological things are unraveling, let alone the care plan at home's got switched off. And so it goes, isn't it? So it's, as you say, it's having the single source of enough truth at the front door, isn't it?
Well, I can add a little story to that. So in many cases, the coordination just between the ambulance service and the emergency department is completely broken. And so in our trust, we are connected to CCAM, and they bring in an iPad, which we sign. That record from CCAM is printed and then attached to the notes. And any information on that then has to be retyped by me as a doctor into the notes. And the actual ambulance handover does not get added to the electronic record until after the patient leaves the emergency department, and it is done so through a photocopy, a scan, which ends up on the e-notes and not as a piece of structured data. I mean, that is a hugely important interface, and we can't even get that right. Because it's difficult, and it's difficult when what you're trying to do is to bring two big systems together. And what we would say is that actually you shouldn't do that. You should delegate coordination to a specific coordination platform. We would want it to be careful to allow both organizations to see and download, copy, paste, whatever is coming in from each. To your point, Anthony, yes, you could make that automatic, but trying to get one organization, a huge organization, to talk to another huge organization to get this little bit of coordination is actually really hard. And so we think that actually you should just delegate that to a coordination layer, which is nice and user-friendly and very and agile and configurable. So it doesn't matter. I mean, it can be everything. So your point, Jonathan, is if the person you're talking about is a frail elderly person with 40 drugs, which they often are, I'm not going to spend time typing in 40 drugs. I go as per ambulance sheet and hope that somebody can see that at some later stage, which they often can't. So anyway, I'll leave it there as just an example of how coordination is difficult.
I just wanted to make, I know we've got about 10 minutes left, but just wanted to comment on something John Paul said. about the evidence that when you have a couple, that the person looking after the frail person then begins to suffer. And actually, this is, the scale of this issue is almost incomprehensible, because actually the number of people who require care at home, who are being cared for by literal children or their partner or somebody who's trying to work a part-time job while also caring for someone is there's hundreds of thousands of people doing that day in, day out. And the socioeconomic impact of that is very great as well. So it's pretty wide varying this.
I'll just move on before you come in, Anthony. I think Sue has said that that at North Bristol, all of the records that I mentioned that are not joined up are joined up. That's going to be the case in lots of different places, that you have a bunch of joined up care and joined up records, but there will always be a boundary. And at that point, you need to have something which helps you join up. Until we have a comprehensive unitary record for every single patient interaction across the entire NHS, which we never managed to do with the National Programme for IT, there's always going to be a boundary somewhere. So is it between the GP and the trust, or is it between the GP and the neighbouring trust? Is it between the community services? Are the physiotherapists the community trust? No, there's always a boundary somewhere. And so where you may solve that particular boundary, another one will pop up somewhere else, and solving those are often very time-consuming and difficult.
Yeah. Well, this has been brilliant so far. I'm really pleased. The report has run, so I'll share that screen. Screen, which tab is it? It's this one. Great. So this is hitting the ground running, getting your feedback on this as we go. It'd be great for you guys to look at, I'll scroll down, give you a chance to have a look, and then you feedback as we go. We've only got 9 minutes left now, but just an overview of the report. So this has been done in this hour. What I'm trying to do with Insight Junior is get everybody over this mental frame of it takes months and costs tens of thousands to do qualitative evaluation. I'm hoping that we're showing that we can do really valuable qualitative evaluation within an hour. So that's what we've got here. So we've got our exec summary. So really interesting that on the whole, there's a really positive slant on your sentiment around the solution today, guys, which is good. Top 5 insights, just let you have a look at those and then see if there's any comments you want to make. And then we've got the quick 3 wins down here. What are your views on these insights and the quick 3 wins? The 3 quick wins.
Well, I mean, straight off the bat, acute trust pressures and financial constraints. I don't think there's anyone in the NHS who wouldn't relate to those comments. I think that's, the part and parcel of the conditions that everyone's working in. But, this is why this is more important than ever, to kind of reduce that overhead of burden so that there's some freedom to make some culture change and change in the way things are flowing.
Yeah. And how do the quick 3 wins feel?
Well, I certainly understanding the budgetary and decision-making hierarchy can facilitate better strategic execution. That's quite a ChatGPT response, but I get the point, which is actually it comes down a lot to the money, doesn't it?
Yeah, it does. I mean, the purpose for this, we won't have had, we'll see in a minute, we won't have had hundreds of responses. So the more you can spread this and get it to the key stakeholders, the richer the information becomes.
Yeah.
But I'm hoping that this is a report that you guys can take away.
That looks great.
And scrutinize, and it can help you build the solution further and further forward. I know this discussion has probably been helpful. It's been really useful for me. But these are the views on the solution. So this is just more detail behind those exec summary points.
So can I just check that you'll be sending that to the chat in the event? Is that right?
Yeah. So I'll send this through. I've just put a link in the comments again for anybody that wants this report. There's a link just to go and tell me what your email is so that I can email it to you. Before I email it, I'm just going to go through and double check the information that's been entered, that there's no personal data in there. But that'll be a 10-minute job, and I can email it this afternoon. So the strengths to it, the challenges with the system. So I don't know if you guys want to have a quick look and a quick reflection over these, and then we'll quick look at the improvements to be made. We've got 5 minutes left, so we've got a bit of time.
Yeah, I mean, just that barriers and patient mobilization actually is a really interesting pickup, because I definitely experienced that on care of the elderly wards, where it's almost like a pedantic adherence to the order that steps need to be taken, or you don't have this title, therefore, even though you're a nurse, you can't stand the patient up outside of bed, which is ludicrous. So, you know, things like that, when you just have even a simple 24-hour delay, you know, it just has such a significant impact on someone's recovery. I mean, when it's your loved one that you're wanting to get out on the Friday afternoon rather than the Tuesday morning that inevitably happens, you know, little bits add up to better outcomes.
Yeah, and I think just to say a general comment on, you know, the issues that have been picked up are around current methods of breaking through to the right stakeholders and the man, as DJ said. But you know, the utopia is to get to a place where if WhatsApp can be used freely, why can't Careful?
Yeah. No, absolutely.
That's a very good point, Ruhi. Actually, maybe we should be going into bat with that question.
Yeah. And then we've got some extra feedback here about what improvements could be made from the context of the people that have submitted. And again, you'll want to just sit down and read this in detail and consider it. And I guess the recording today will be good to reflect on as well.
Excellent.
What else? So there should be some recommendations in here in terms of where to go and look and what research to do. And
just
then,
as a very quick point, I want to point out something Sue said about nurses are scared about moving patients. So if they had better insight into the most recent physio notes, for example, rather than those being in a folder in the physio's office, maybe that would help facilitate, you know, removing some of that fear around, you know, what could potentially happen.
Or just if somebody who then says, oh, but we've got all our physio notes on Epic, you go, yes, and requires you to go back to the nursing station, fight for half an hour for access, then find the physio. So the idea that whether they're in the physio's office on paper or whether they're in the lumbering EHR makes no difference. If they're not in an agile and easy way available for you to flick through to see that this patient has got physio, this is the latest thing they said. That level of real close interaction of teams is what's missing. You're right.
You want it in your back pocket, basically, is what you're saying.
Exactly.
You know, you can pull it out of your back pocket wherever you are and start, you know, addressing the issue.
Exactly.
Yeah. So I'll quickly whiz over this then, but the gist of it is that once you've gone through these as a team in Careful, you can go through these and go, okay, which are the things that we've picked up from this that we're actually going to do some more work on, who's going to do it and by when and that sort of thing. So just a bit of sensible PMO. I'll just share that this is the source data that's come in from the audience. So there's about 5 people there that have fed back. So that's good. We've got some content, but obviously if we've got 50 people in there, it'd be richer, just to give everybody that feel. But it's important that this is there, because anybody that then reads this report can see that it's not been made up. It's not hallucination. It's come from that source data, but we've made sense of it really quickly, and we've generated that within an hour. So I will send that through to you guys, and hopefully it's been really useful for you as a team.
Well, very much so. And I'm
hoping that's.
I want to thank you. I also want to thank the people online for their interactions and for filling in the Insight Genie, which I think is genius. A very, very clever system and really useful for us. Thank you.
No, brilliant. And I'd really appreciate your feedback afterwards, guys, in terms of when you get that report, what's been useful, what you think, you know, if there's, in the same way that we're asking for feedback on your system today, if you can feedback on Insight Genie and how that can be improved, that'll be fab. So we've done it. We've done everything on time. I've really enjoyed it. I've learned a lot, and well, I'll definitely stay in touch and hopefully have you on the panel for future sessions with other things, but also maybe we could do another one of these in a few months' time to show your progress and see what's changed maybe as a result of this session. That'd be fabulous. Thanks, everyone. Time for lunch.
Thank you
and I'll
again.
see you all again soon.
Thank you for inviting us all.
Yeah, thanks a
Thank you
lot.
very much.
See you soon. Thank
And
you.
some
Bye.
great comments just coming through from Chris and Haley as well, and Sue.
Yeah, thank you. Thank you.
Yeah,
Haley.
brilliant. Thanks for the contributions, guys. You make it more lively. Thank you.
Bye-bye.
Cheers.